So we have Mr. W with us, who's a 63-year-old male with lightheadedness and non-sustained ventricular tachycardia, past medical history of hypertension, bilateral carpal tunnel release a few years before presenting, which was in 2016. So about 8 to 10 years before presentation. And then who has an NT-proBNP of 695 and has a troponin of 0.06. This is the EKG, and what you can tell from the EKG, that's something that I've been talking about for a while, which is low voltage. You can essentially look at the table and try to think, why would someone like Mr. W has low voltage? And so you start like really thinking about this. And then this is the echo, which we're going to see. You can see the echo. This is the original echo. It's actually not too thick. It's actually just mild to moderate LVH. That almost always I see it just being, this is hypertension, old age, move on with life. And so it's not actually too much. But what caught the attention is the low voltage and the NT-proBNP. That's what caught the attention. And so you can see here, this is an MRI. You really didn't necessarily need an MRI, but the LVH was not that much. And so that's why they went for an MRI. You can see here, there is diffuse late gadolinium enhancement. So white on that second picture is diffuse late gadolinium enhancement, which is abnormal. Gadolinium is not being washed out of the body. And then this is a PYP scan showing you, SPECT CT showing you that there is diffuse uptake of the tracer in the myocardium, not the blood pool. It's really important to differentiate where the uptake is. All right, now we can switch over. Thank you. All right, so we're going to ask Dr. Kari to give us some commentary on what she's seeing on the pictures.
Well, I always pay attention to my patient's rhythm as well. So it looks like it's probably atrial fibrillation, and keeping that into account when we're kind of looking at some of the images and what we acquire and cannot acquire. That's always important. So obviously most of our times, sometimes it is when we just put the probe on the parasternal long axis view that you're like, oh, yeah. You just notice, I think, and it's mainly the sonographers who do the kind of a lot of that initial assessment when they first put the probe on the chest and see the echo and say, oh yeah, look at this increased wall thickness. One of the real key findings that we found kind of systematically when we looked at several hundred patients was posterior wall thickness. So we're looking at a population of patients, obviously a lot older patients, where we see a lot of discrete septal thickness. So sometimes you can see that septum looks thick, but what the real clue can often be is posterior wall is also thick. So generally the rule is kind of 12 millimeters for increased wall thickness. We found that a posterior wall thickness of 14 millimeters was a really kind of good clue to the presence of amyloidosis in an older population cohort. Nearly performed better than some of these kind of multi-parametric scores that they talk about. So we can see now Jim is measuring that here, and we're seeing 17 millimeters, so definitely abnormal. So that can be a lot more reliable than the upper septum, where you can get just dust that we see as we described discrete upper septal thickness. The increased atria size is also another kind of key feature, so we can see that LA looks quite dilated. And then I think it's kind of what Amma was pointing out earlier. One of the key things is just that lack of longitudinal motion. So we're seeing that there's like radial motion, we can see that it's getting closer together, but we see that lack of longitudinal motion on the parasternal long axis even. It's probably better in the apical chambers, but you can even start to notice it here. I don't know if you have any other comments to make on the views.
No, this was perfect. I just want to mention that this echo is being done 8 years after the initial diagnosis. And so we would have given a round of applause, but we don't want to distract Mr. W. But I think one of the things to remember is that this is actually, it does make a huge difference. It does make a huge difference picking up this disease earlier. Really, really a great difference in doing that.
And also what I'd say about making the wall measurements, the septal wall, you can often kind of include that like moderator band, RV trabeculations. There can be some inaccuracy, but sometimes if you get a good posterior wall, it can be a very reliable measure. So obviously we're about to look at the RV inflow view there.
I think one point to make is that if you have severe valvular disease, mitral or tricuspid, where it looks like it's restricted, but you don't have anything else going on besides LVH. So LVH with a thickened mitral or a thickened tricuspid that looks restricted, also that's another clue to think about amyloid. Because these tricuspid valves, which is not the case here.
No, his looks lovely and thin.
Yeah, this one looks great, but like when the diagnosis is a little bit delayed, these tricuspid valves look like they actually don't want to move much. And so, nobody tests actually on this in the exam, of course. Everyone thinks of carcinoid when that's the case, but it's not. These typically are valves that still touch together, that they still can get together, but they're thickened and they're a little bit lazy. And that causes severe TR or severe MR not infrequently. We probably can move on to the apical chamber there. And then we can here spend time doing some mitral inflow and diastology as well.
Yeah, so then one of the things that we often hear about amyloid and echo that we like to talk back about is the granular sparkling, or the starry eye, star in the sky appearance, or that just change in echogenicity. So sometimes it's just there to the eye. When we try and look at it systematically for like writing up papers, it's really hard. Like I would swear I see it all the time, and then I looked at like well over 100 studies, and I didn't even agree with myself when I had to like look at just the septum and then just a focus of the septum. So it's not like that reliable anymore, and that's all got to do with the change of going from fundamental imaging to harmonic imaging. So now with kind of the ubiquitous use of harmonic imaging, we can't really rely on the texture visually. Obviously, sometimes you just say it's there, the texture is abnormal, and I would say definitely go with that instinct. Because if you're thinking, oh, something's looking funny, the texture's looking funny, put it in your report. Say possibly because there's you might as well err on the side of caution by putting it in. But what I would say is, if it's not there, it doesn't really mean anything. And it can be found in other diseases or seen. It's very hard to differentiate. But I think if you see something like that and it triggers your memory to think of amyloid, just stick it in the report.
That's an amazing point. I think if you look at echocardiography, and if you're an echocardiographer, we frequently actually don't commit to things in the report. We are very descriptive because we're using to being descriptive and giving the report back to a cardiologist. That's not always the case, actually. That's not always true, first of all. And second of all, not everyone thinks about this disease. If you see something like that and you want to, in a way, force someone's hand to actually act on it, you need to name it. That's why with MRI, actually, the performance is pretty incredible with MRI for amyloid, because everyone writes down findings suspicious for amyloidosis. Very few people do that on echo. And so that's what we need to essentially change. The other thing I was going to mention, look at how robust this ejection fraction is.
Yeah, that was striking me.
But this is only a volumetric measurement, correct? Look at how, I don't know if you can see me or not, but look at how the LV, the four-chamber view, it's essentially just clapping, coming in, correct? Why is that? Because your circumferential and your radial strain are preserved in a way in someone like Mr. W. However, your longitudinal strain is really poor. And so you're not having shortening. So the heart is supposed to go in 3 directions, correct? It's not clapping. It's actually going down in 3 directions with rotation. That doesn't happen here. And so that's why if you look at enough of these echoes, you start seeing this pattern of things coming in and going back without shortening whatsoever. That's essentially your GLS without acquiring, necessarily strain and the complaints we always talk about.
Yeah, so I think this is a lovely apical four-chamber view, kind of demonstrating that. And we see the atrial dilation as well. There's been talk of a thickened intraatrial septum, but you can kind of appreciate possibly here that it is.
Yeah, and Jim, if you want to show us a mitral inflow and then tissue Doppler, I think those would be very useful here as well.
Yeah, and I think that's it. Like even in AFib, you can get a lot of information. As Ahmed was pointing out earlier, like the S prime can be useful. Just having your E velocity, having your deceleration time. Because often sometimes you'll just kind of click a button and say AFib, diastology, incomplete or unable to assess. But I think it can be really valuable still if you can just even give an E over E prime average. Forget about your A wave or your A prime when you're in AFib, obviously. But just so you can kind of say, yeah, look, it's restrictive looking. Like that kind of pattern did look like restrictive with that really steep deceleration time. And then if we can just even give like an E prime to say it's less than 5. So there is also the S prime less than 6 centimeters per second is pretty sensitive. But also the 555 signs some people talk about. So having all your tissue Doppler velocities less than 5 can be a real giveaway. Again, which we see here, an S prime less than 5 and an E prime less than 5. So definitely, and that's in those kind of patients that you say, oh yeah, it could be just hypertensive heart disease. It has to be really bad hypertension to be getting your walls that thick and this kind of restrictive pattern. And I think it's just still vital to kind of put these into the report, even in atrial fibrillation, even if you're not kind of giving a grade of like diastolic dysfunction, but at least that you're giving these metrics.
Excellent. And that's a good point about hypertension. If you don't have kidney disease, hypertension cannot damage your heart on its own. And so you need to have some element of some kidney disease. The second point is, if there is no kidney disease, your NT-proBNP will not be high. It will not be in the thousands. That's almost a guarantee if there is no significant kidney disease with hypertension. And so here you're looking probably at lateral.
It's pretty nice.
Yeah, fantastic. And so look at the S-wave. It's close to 5. The reason why I say keep this number in your mind, because most of the echo acquisitions have a 5 and 10 for their tissue Doppler, 5 centimeter per second and 10. You can just peek at this in 1 second. You don't even have to measure it. And normally it's almost always closer to 10. While when it's highly abnormal, if the EF is okay, and of course forget the people who have lateral MIs and all that stuff. But without having an MI and a mitral ring or a mitral repair or a mitral valve, this essentially should work very well for you. And I think we can move to trying to show how we do strain imaging.
So sometimes we are a little bit spoiled in amyloid for doing strain because we have that bright echo, like myocardium, and we have a thickened wall. So it can be a little bit easier to acquire strain in patients with amyloidosis. One of the main things that we really focus on in our lab is how well the region of interest is drawn. So I know as the scanners kind of get updated more and more, it becomes more automated. But sometimes it's key just to make sure that like it is tracking the myocardium well. It's not, depending on what vendor you use, you kind of need to know exactly where the line should be, the kind of focus of it. I think with the GE, we tend to kind of try and cover 90% of the myocardium with our region of interest, making sure it's really tracking the endocardium well, and definitely that it's not going into the epicardium, like beyond the epicardium and kind of on where it stops tracking.
So yeah, I did a rookie mistake and didn't look at my frame rate. And again, it has to be between 40 and 80 to 100. So, and because he's AFib, I put it out to 3 beats, so you can kind of fool the machine if it doesn't like the differences in the QRSs. You can pick 1 out of the 3 and maybe fool it to think that it's in normal sinus, or at least R to R interval is good. So.
Yeah, I agree with you, Jim. We usually get strain kind of whenever we scan a known patient with amyloidosis. We have a click button in our request to say amyloidosis or cardio-oncology, so the techs will know to do strain at the time of acquisition. But sometimes we end up having to do the strain post-hoc, and we'll often do that on a GE PACS machine. And I hate the AFibs, but luckily now they have a new package where it'll kind of automatically match up the R to R intervals across the 3 views, because that was always the bane of my life when I had to go back and find matching RR intervals, and I'm like, which one didn't agree? And that's what's kind of key. It's just getting, for me, it was on the post-hoc, when I had to do post-hoc, it's just getting 3 really good views, high frame rates, kind of focused in the apical 2, 4, and 3 chamber. Yeah, nice. So we kind of saw that kind of hint towards the apical sparing pattern. So there's been so much published on the apical sparing pattern and the ratio. So there have been different cutoffs used for the ratio, and often it's kind of the average of the apical segments over the average of the basal and mid segments. And if you have a ratio greater than 1, that's supposedly highly sensitive and specific for amyloidosis. I would kind of say you don't need to be calculating the ratio. You just need to eyeball it. Because these ratios were calculated in very in smaller numbers of patients with very specific diseases, like comparing amyloidosis with patients with hypertrophic cardiomyopathy, which isn't truly maybe reflective of the exact population. So I don't think we need to focus in on an exact number, but I think we just need to focus in on the pattern. And when we see that pink and green line are moving much better than the rest of the segments, so the pink and green are the two apical segments, and when they're being displaced way more longitudinally than the mid and the basal, that's a really good hint that this is cardiac amyloidosis. So we've really given you a challenge with the AFib, haven't we, Jim?
No, that's all right. So another thing I want to also bring about on strain here is the traces. So sometimes you have this little initial upslope, and you can see it contract. So usually in this view, you can bring this down to where it should be, to where, because it's supposed to be where the aortic valve closure is. So sometimes you get this in like a bundle branch block, so bring it down, and then, so you see it changes this, because a lot of times it only takes like the greatest distance from the zero. So as you can see, this is a greater distance than this, but you can see that it contracts. And again, you can only change these when you're in this view. So keep that in mind, because it's supposed to be like when it contracts up to the aortic valve closure. So, and that changed the map there. And of course, we got the nice little.
Yeah, we've got beautiful apical sparing or cherry on top. Yeah.
Alrighty. And so negative 12.4 is the average. Another neat little thing is the standard deviation of all those, and the closer to zero is better. And once it gets over, I believe, 80 milliseconds, that a lot of times it's like desynchrony. So that's just something else to keep in.
One important thing to remember is that you want a systemic disease to affect your bases in a reasonable fashion. And so if you only have the septum that has low strain, you have to ask yourself, why am I dealing with a systemic disease or not, and what's going on? For example, if it's only the septum, that's more common in hypertrophic cardiomyopathy. But the thing we see is that we sometimes see like certain segments, workings, other segments not. So you might sometimes not be able to rely totally on your strain. But also if someone had an MI before, your strain essentially gets thrown away, because for that segment that is infarcted, that's not going to work very well for you. And also if you don't have good images. But I'll go back to the same principle. We're looking for the bases of the heart, not shortening. And you can do that with strain, and you can do that with other surrogates. And so in our practice also, we try to do strain for everyone. There's a little bit more challenge doing strain in younger patients, because some of the payers and insurance carriers don't allow you to do strain and actually include it in the report. So that can create some problems there. I don't know if you, Sarah, can you think of anything else we would want to see, or we would move on?
I just want Jim to show us his lovely example of where the tracking that he got on the strain, because I think it was just a nice example to see the regions of interest, where they were situated and how well they were tracking. I think the key is like, especially if like you're in a lab where you're kind of empowered at the scanner to say, oh, I'll just throw on strain here because I see this thickened LV, and especially if you see the thickened LV wall and you say, maybe I'll just do strain and see what it looks like. And if you ever see that kind of apical sparing pattern, it's totally worthwhile putting it in again to the report, kind of highlighting apical. And I often one of my pet peeves is sometimes when you see the apical sparing, someone will say, consider infiltrative cardiomyopathy. I'm like, just say amyloidosis. Just say consider amyloidosis, because it can kind of get lost in translation. But yeah, we just see how well every segment here is tracking, and it seems to really, really track the endocardium very well. We're not seeing that it's really moving very well with the heart muscles. That's kind of what we want to see for our quality control.